Hello, I would like to thank the ICS for allowing us to present our data. My name is Goueli, and I will be presenting on attrition rates and predictors of long-term continuation of treatment with onabotulinumtoxinA intradetrusor injections for refractory urinary urgency and urge incontinence. We have no relevant disclosures, and this is a self-funded project. To begin, there's a high attrition rate with continued onabotulinumtoxinA intradetrusor injections for urinary urgency and urge incontinence, but there's little data known on predictors of this therapy in the long-term sense for refractory urinary urgency and urge incontinence. Therefore, we sought to determine the attrition rates of onabotulinumtoxinA, otherwise known as Botox therapy, and potential demographic and urodynamic factors predictive of long-term continuation of therapy. Our methods are listed here. We have an IRB-approved, prospectively maintained database that were reviewed between the years 2007 and 2019. We included any patients who underwent a trial with Botox injections during our study period for refractory urinary urgency and urge incontinence and had at least 5 years of follow-up. We excluded any patients with a history of GU malignancy, GU fistular malformation, or previous bladder augmentation, and any issues with poor bladder compliance, which was the reason for their Botox injections. Interestingly, in the studies, patients participated in self-directed injections with instructions to call for additional treatment only if they perceived significant benefits. The data that we collected, you can see here, are baseline data, UDI-6 questionnaires, pre-op UDS, and Botox dosage. We define continuation of therapy as continuous treatment with Botox duration over 5 years. You can see our demographic listed here. There are 186 patients who met our inclusion criteria, and of those 186 patients, 72 met our criteria for continuation of therapy. During this study period, a total of 1,021 injections were performed. The majority of patients in the cohort were female. The majority of the patients were neurogenic, with the respective diagnoses listed below. You can see their bladder management strategies listed as well, and the patients that were currently on medical therapy at the time of injection listed there. All patients had failed at least one or more oral therapies, but these were the patients that maintained medical therapy at the time of injection. You can see our urodynamic and UDI-6 parameters listed here. You can see that the majority of patients underwent injection with 200 units. The mean follow-up for this cohort was 6.6 plus or minus 1.9 years, and patients who continued therapy for over 5 years received an average of 8.3 plus or minus 4.1 injections during that 5-year study period. You can see that there are no urodynamic or baseline symptom scores predictive of therapy continuation. On multivariate analysis, age, female gender, and a diagnosis of neurogenic overactive bladder were predictive for continuation of therapy for over 5 years. On multivariate analysis, female gender and a diagnosis of neurogenic overactive bladder were predictive of continuation. No specific neurologic diagnosis was associated with continuation of therapy on either univariate or multivariate analysis. You can see our Kaplan-Meier curve listed here. We had an attrition rate of 60% overall over the 5-year study period. But on the Kaplan-Meier curve to the right, you see a subgroup analysis of idiopathic versus neurogenic overactivity, with the neurogenic patients having 43.7% rate of continuation after that 5 years. When we further stratify based on gender and diagnoses, you can see that male patients listed in blue had a 90% attrition rate after 1 year, and the remaining of those patients listed above. In conclusion, nearly 40% of patients continue with Botox treatment after 5 years. Female gender and a diagnosis of neurogenic overactive bladder were predictive for continuing therapy for over 5 years. And then it's worth noting again that males with idiopathic overactive bladder have the highest attrition rate. The strength of the study is its real-world experience with Botox adherence and continuation of therapy. This is a large cohort with a long follow-up. This is a single surgeon experience, therefore the technique of injection is standardized, and this is patient-driven therapy that patients are requesting it on their own. The average time between request and injection was about 20 to 25 days. The limitation of the study is this is a retrospective analysis, therefore limited by inherent quality of past data. We did not assess for Botox A antibodies after secondary failure. Patients could have sought care elsewhere to receive re-injections and not told us at the time of follow-up, and that this is patient-driven therapy. We are relying on patients to call for follow-up, but some patients require a little bit more encouragement in order to continue with this therapy. We thank you for your time and your attention. Any questions can be directed towards the following emails.